Hello everyone, my name is Catalin Ivan and I'm a consultant radiologist. Today I want to suggest to you what you should be aware of or what you should have in mind before requesting radiology scans. The aim or the learning objectives of this presentation are to illustrate to you what image modalities we have available, what are the safety issues related to ionizing radiation, MRI considerations, and IV contrast, what you need to provide to the radiology department when you are requesting a scan, and how you should be preparing your patients for interventional procedures. Obviously, radiology is a technologically driven specialty, and we can offer a wide arsenal of diagnostic modalities to diagnose diseases, starting from X-rays, fluoroscopic studies, ultrasound, cross-sectional imaging, and this is where I'll mention CT, MRI, and PET-CT scan. But also, nowadays, we can treat patients with the aid of interventional radiology. The main point of discussion, I think, should always be, when it comes to radiology, should always be radiation. Obviously, ultrasound and MRI do not involve radiation, so we can just crack on and discuss about X-rays and CT scans, along with fluoroscopy. You will see on this slide that we measure radiation in millisieverts, and you will also see that a chest X-ray, when you compare it with the UK background radiation, gives the patient a very, very small dose, but a CT body will give the patient a much larger dose. The risks associated with radiation, as pointed out in the literature, are carcinogenesis, genetic risks, and developmental risks to the fetus. This graph illustrates a selection of ionizing radiation radiological investigations, starting from CT scan on the left and ending with dental X-rays on the right. The blue bar indicates the frequency of these investigations, how frequent we do them, and the red bar illustrates what's the dose burden in the population are these investigations associated. And you'll see that although we do much fewer CT scans than dental X-rays, the radiation burden associated with the CT is much, much higher. And I also want to bring to your attention, for example, abdominal and pelvic X-rays, and also lumbar spine X-rays. If you look, the red bar is quite high, so there's quite a lot of radiation burden associated with these investigations, because these will cover or involve abdominal and pelvic organs, which we know they're very, very radiosensitive. So always bear in mind when you request these investigations, just don't treat them lightly just because it's an X-ray. Okay, what does this mean? Well, 29,000 of 67 million CT scans done in the US, that were done in the US in 2007, would result in further cancers, and nearly half of those are associated with CT scans. So this is just to highlight the previous slide. Interestingly, 1 in 270 women and 1 in 600 men who have a CT scan of the heart at age 40 will develop a cancer. And then this risk is doubled for 20 years old. So this means that the younger you are when having ionizing radiation, the more likely you will develop a cancer. Also, just bear in mind, the reason more women than men develop cancer is because we are talking about CT of the heart, and breast tissue will be in the field of view. And the breasts are radiosensitive organs. So always keep that in mind when you are requesting CT pulmonary angiogram for young female patients or pregnant patients, as this is an important risk you need to mention to the patient. there is evidence in the literature that that of the carcinogenesis risk, and important journals such as Lancet have papers published in. And again, this is a population of children. If you look at the interpretation of the scan, and in 10 years after the first scan for patients younger than 10 years, and we are talking about CT head scans, there is one excess leukemia and one excess brain tumor per 10,000 scans. So some may argue it's not a high risk, or statistics are not that, but who are we to judge what is a small or a high risk when it comes to someone else's child? There is a website I recommend to you. It's called xrayrisk.com, where if you are interested, or if the patients ask you what is the risk associated with my scan, you can just go and fill in the details. For example, you can put a female 21 years old. We're doing a CT chest, abdomen and pelvic CT, so you can tell the patient 1 in 263 patients of your age having this scan will develop cancer in the future. So I think this is a useful tool for you to be aware of. There is legislation to protect patients called Ionizing Radiation Medical Exposure Regulations, which was published or updated in 2000. And this framework, the main points or the main aim of this is to minimize unintended or excessive and incorrect exposures to ionizing radiation, to make us justify each exposure, and to optimize the diagnosis using as little radiation as possible. And you can see here it includes you as the referrer, as a doctor who's requesting the scan. You are the referrer, and you are bound by legislation to provide sufficient clinical data to ensure that the exposure can be justified, and adequate demographic data so that the referred patient can be correctly identified. And you have to provide the clinical diagnosis, the clinical findings or on examination, and any available important histology or relevant previous investigations. When it comes to MRI scan, I guess you could think about when we're talking about an MRI machine, you can think about it as a huge or very powerful magnet, and the let's say the workhorse in terms of MRI is the 1.5 Tesla, and that would be around 35,000 times stronger a magnetic field than the Earth's strength. So it's a very, very powerful magnet. That's why if patients have metal foreign body in the eye, you don't want to put them in there, because that could be dislodged, or brain aneurysm clips can be dislodged. You can understand why these are important considerations, and you should be asking patients before having the scan, do you have a pacemaker? Do you have any medical device or any foreign body anywhere in your body? This YouTube short video, I will try to click on it. Fast forward. This is just to give you an idea of the potential hazard when it comes to MRI scan. Like I said, it was just to give you an idea of the power of this magnet. Now, the risks associated with IV contrast, the most important I would mention is previous contrast allergy and anaphylaxis. And this is where we need to be careful. If this happens, obviously we have to follow the UK Resuscitation Council's protocols to treat these patients. Contrast-induced nephropathy is inducing an acute kidney injury in a patient by giving them IV contrast. It's becoming slowly a historical complication just because the agents, the contrast agents the industry produces are much, much better. However, in the clinical practice, the threshold we get in touch with you is an EGFR of 30. So if it's less than that, then, and if the scan needs to happen, then we will ask you to hydrate the patient before and after the scan, and also to monitor the renal function after the scan. Contrast soft tissue extravasation happens quite oftenly because we use a pump to inject, a mechanical pump to inject contrast in the venous system. There is a theoretical risk of compartment syndrome if that contrast is introduced suddenly and at high pressure in the compartment of the arm or forearm, and that would reflect clinically as pain out of proportion. The treatment for compartment syndrome is fasciotomy, is surgical treatment. I've never seen it in my career, so it's often that the contrast extravasates, but it's not often that it will induce compartment syndrome. However, in these patients, we recommend they keep their arm elevated and put ice. MRI scan uses gadolinium-based contrast agents. The allergy to these agents is rare compared to iodine. There is a risk of gadolinium retention and nephrogenic systemic fibrosis, which is an absolute clinical disaster, but it happens very, very rare. And it will happen. If it happens, it will happen in patients who have severely impaired renal function. So again, we will look at the EGFR when you request scans, but this is really, really rare. They're quite safe otherwise. In some patients where we want to image, let's say, the bowel, we can do a CT colonogram where we introduce a urinary catheter through the back passage of the patient and we insufflate CO2. We want to relax the bowel, otherwise this would be a really, really painful investigation, and we would give the patients Buscopan, which is a cholinergic agent. And obviously you need to be aware of risks associated with that. And this would be unstable cardiac disease, glaucoma, myasthenia gravis, and so on. I want to quickly mention some NHS national tariffs, just so you're aware how much, a basic outpatient ultrasound fluoroscopy study, CT or MRI scan costs. But think about it as an additive cost, because all these patients will have follow-up scans. You do an ultrasound, that's inconclusive, then you go on to do a CT scan, that may be inconclusive, and then you'll go on to have an MRI, so think about it as an additive cost. This is, I think, a very, very useful website, Radiology Cafe, where you can just read what the basics of requesting imaging are or should be, and what are the simple steps of you as a foundation doctor requesting a scan and having it accepted in a timely fashion, where you don't have to chase radiologists in the hospital and so on. So it is very important to provide patients' details, because we want to make sure we are imaging the right patients. What are the clinical details? What are the signs, symptoms? What are the imaging, what previous imaging results? What are the blood results? What are the observations in these patients? What is your clinical question? What do you need? What sort of investigation are you looking after? and then give us some background relevant clinical information. If you're looking for bowel obstruction in a patient who previously had surgery, just tell us. That would help us provide a better report. Or if you tell us the patient has cancer already, we're not going to jump off the chair and call you and saying this patient has got cancer with metastasis, because it's something we knew about already. In terms of clinical details, tell us the clinical scenario. For example, a patient is post-surgical. What's happening now? What has changed? Well, there's increased short of breath and cough. What are the results, in terms of observations, in terms of blood, in terms of your clinical examination? Have you done any tests that would help you to narrow the clinical diagnosis? Have you done a well score? If you're requesting a CTPA, and so on. So the tips are: know your patient, or have the notes and the results at hand if you are calling the radiologist. Know why you're requesting the investigation, what are you trying to find out, and what investigation you need in order to do that. Is your request really urgent? Do we have to do it at 3 o'clock in the morning, or can it wait until 9 o'clock in the morning? And always try to be polite. Do not use words as "I've ordered an investigation." It's called requesting an investigation. And know the patient and give reasons. Make a referral rather than just saying "my consultant requested it," because then we'll just say, "Well, I want to speak with your consultant," and that's not going to help you. So I'm just going to give you some examples of these are print screens of what some of the requests we receive, and I will let you judge whether they're appropriate or not. So this is a request for a lower limb DVT. I presume it's lower limb. It says to rule out DVT. It could be upper limb, it could be left, right, we're not sure. A CT pancreas, triple phase. So these are 3 CT scans of the patient in different phases of contrast, and the information we have: jaundice and new onset of diabetes. There's no clinical question provided. A chest X-ray just says pain and shortness of breath, chest infection. There's no information if the patient is coughing, no information of inflammatory markers, of negative or positive troponins, and so on. I'm just going to read it to you. I mean, there are a lot of spelling and grammar mistakes in this request. It says patient have fall slid out of bed, was 7 hour on the floor, checked by staff of warden, controlled, unable to get up the floor, denies hair injury, LOC, dizziness, patient is SOB, shortness of breath. I mean, I can't really read this. Essentially, they want a CT head, but then they're saying no signs of head injury. So yeah, you conclude. This is a chest X-ray request saying as previous. Well, then why are we requesting it? A CT abdomen. Patient is 1-2 weeks post-laparotomy. Well, is it 1 or 2 weeks post-laparotomy? I mean, these are important pieces of the puzzle, and you have to help you. Just think of it this way: the more relevant clinical history you provide us, the better our report is going to be, and it's going to help you. And I'm just going to give you some examples of how I would personally request a scan. And the key is to provide important information, but we don't need to write pages. It's just try to write bullet points and provide really focused clinical information. For example, if you have a patient with query appendicitis, say acute onset of pain in the periumbilical region which migrated in the right iliac fossa, there is voluntary guarding in the right iliac fossa and positive roving sign, there's anorexia, increased inflammatory markers, so you're looking for appendicitis. This is straightforward, it's going to be accepted 100%. With chest X-rays, for example, 3-day history of cough and mild pyrexia, right basal crackles on auscultation, increased inflammatory markers, so you're looking for chest infection, 100% is going to be accepted. CT renal tract 4 stones, kidney uretery bladder it's called, so acute onset of severe right right loin to groin pain, please mention the side, minimal response to pain medication, microscopic hematuria on urinary dipstick, question mark renal tract calculi. Again, just a few lines, straight to the subject. DVT scan, 1 week history, unilateral leg swelling, poor mobility, tender calf on palpation, no evidence of infection or inflammation, question mark DVT, straightforward. CT abdomen and pelvis, 5 days post-laparoscopic appendicectomy, so I'm very precise telling the radiologist when the surgery was, because there will be, depending on when the surgery was, there will be different complications associated with that surgery. Intraoperative perforation of the appendix, I'm telling the radiologist that this was a difficult operation. The white cell count and CRP remain elevated, the patient is not improving, and I'm really worried that there will be collections. CT pulmonary angiogram, young patient, pleuritic chest pain and shortness of breath, no history of trauma, normal chest X-ray, increased heart rate and respiratory rate, the patient is on oxygen. You can provide a well score, just say normally I see ECG and troponins and question mark P, 100% is going to be accepted. Ultrasound abdomen, young female, acute onset right upper quadrant pain and increased inflammatory markers. Bilirubin is high, so you're looking for gallstones and cholecystitis and CBD stones, straightforward. Now, when you're referring patients for interventional procedures, think of this scenario as you'd be preparing patients for theatre. You need coagulation, you need blood results, you need to make sure that the HB is within reasonable values, transfuse the patients pre-procedure if required. If the procedure is complex, do a group and safe, and be careful, immunosuppressed patients will need irradiated blood. There will be guidelines on the intranet regarding stopping anticoagulation, so just refer to this. For example, warfarin needs to be stopped 5 days in advance. Keep patients kneel by mouth. Pediatric patients will most likely need an anesthetist. Please explain the purpose of procedure and counsel the patient, because it's really unpleasant for that patient to come down at 9 o'clock in the morning and find out that they're going to have a big needle inserted in their liver for a biopsy. So just tell them and prepare them, help them digest the information. Please ensure there is a cannula, because we might need to give them either paracetamol or just to help them out with the pain. And if anything is unclear, just ask your seniors or the interventional radiologist suite. They will be able to answer your questions. Just call. So hopefully, after this presentation, I've given you an idea of what investigations we can do and what risks are associated with these investigations. Also, hopefully, when you're requesting scans, you'll be able just to provide focused but relevant clinical information. And patients who are, when you're helping patients get ready for interventional procedures, make sure they have everything in place and think about it as them having some sort of theatre procedure, because that will help you tick all the boxes. Thank you very much for your attention.